Hi there, my name's Alex. I'd like to present a case of medial knee pain where the cause of the pain wasn't that obvious to start off with. I'd like to cite this as an example of my approach to dealing with musculoskeletal conditions, trying to integrate both traditional East Asian medicine and Western orthopaedic examination to better diagnose and treat my patients. I was quite fortunate in 2008 to meet Jason Robertson, and he invited me to go to China to study with his teacher, Professor Wang Jui, again co-author of Applied Channel Theory. And over the next 5 years, I made regular trips to China and Europe to study both under Professor Wang and the other apprentices, Jason Robertson, John Chang, and Yafim, to better understand applied channel theory, channel palpation, and channel physiology, and then to integrate that within my practice. After a month internship in the Twin R Hospital in Beijing, I came back to the UK and then undertake a 5-year degree course in osteopathy to better understand orthopaedic examination. I founded East West Healthcare 20 years ago with the express aim of exploring the integration of these systems of medicine. Now on to the case study. This is a case of a 65-year-old male with right-sided knee pain. He's quite stressed and finds walking a relief, and he found it quite distressing, the fact that he couldn't walk because of the pain. There were also signs of damp, bloating after a meal, mental fogging, and also heaviness. The site of the pain was the right-sided medial aspect, near where the medial collateral ligament is located. There was also pain going down the medial side of the tibia, around about areas of spleen 9 to spleen 8. The onset was about 3 months ago, of insidious origin. There was no change in work routine, there was no change in chairs, there was no increase in or decrease in movement, no changing of the car that might alter the position of the knee, there was no trauma involved. So it's quite a mystery as to what the cause was. He described the pain as quite sharp, 10 out of 10. It was really debilitating, found it very, very difficult to walk. He had to crawl sometimes to get anywhere. He saw a GP shortly after, which I'll come to in a second. Now the pain was described as a constant ache, 6 out of 10. There was no ridiculous symptoms, no shooting pains going anywhere else, no pins and needles to the periphery. He saw his GP, was sent to the physio, and who was diagnosed arthritis. He was given painkillers and some quadriceps stretches and other stretches as well, which seemed to help. So the pain has now moved down to a 6 out of 10, but it's sort of reached a plateau with no change, and it was a constant 6 out of 10. Certain things made it worse, waking up in the morning, walking up and down stairs, and also at the end of the day, especially after prolonged walking, it seemed to make it worse. What made it better? Rest and heat. Cold or damp didn't seem to make a difference. On patient examination, observation, there was slight swelling around medial Xian, the medial eye of the knee. On the postural assessment, which I do with every patient, he was standing. The ilia, the hips seemed quite level. However, there's a positive Trendelenburg test, which is the Western orthopaedic test and it exhibited right-sided weakness, which I'll explain. I'll come back to that in a second. On palpation, there were tender points on the quads, Schur points, trigger points, and also on the distal IT band, around about the gallbladder channel sinew meridian, around about the areas of gallbladder 33, 32, 31 area. On channel palpation, there were changes on tie-in, both hand and foot, so lung and spleen channel changes, which would confirm the possibility of damp, possibly the tie-in unable to metabolize damp. There's also bilateral changes on J in both liver and pericardium, which would actually correspond with a possible diagnosis of liver qi stagnation, together with other diagnostic questions that were undertaken. And also there was channel changes to the right foot Xiaoyang, the gallbladder channel. Pulses, the pulse was quite slippery on the spleen and also quite wiry on the liver pulse. Tongue was pale swollen with thick white coat and teeth marks and a red tip. On orthopaedic examination, the range of motion seemed on the knee seemed quite good. They were quite equal between left and right, although there were tight hamstrings at the right. So when the patient was lying down flat and I lifted the left leg, it went up to 90 degrees. The right leg only went to about 70 degrees. So it was tight hamstrings on that right hand side. On examination, the iliac crest, the anterior superior iliac spine, and the posterior superior iliac spine all seemed level, and when lying down, the medial malleoli seemed level. So there seemed very little chance of the hips being out either forward or backwards. A cluster of tests that I usually teach on the course exhibited there was there was a very little chance of a disc issue being the cause here or nerve impingement. Again, for the knee tests, the test that I tend to discuss on the knee for the anterior cruciate ligament and posterior cruciate ligament, and also the collateral ligaments, both medial and lateral, and meniscus tests all seem to prove negative. There was nothing untoward there. However, when lying flat with the knees bent, the hip flexed and the knees bent, I've got the patient to straighten his left leg, and the patella seemed to track quite well. But as he straightened his right leg, the patella seems to kink as we straighten it down, which indicated there was some kind of patella maltracking there. But the key thing here from earlier on we discussed is this Trendelenburg test, which can indicate there might be possibility of a weakness of glute med, and will be confirmed by manual muscle testing. I'll explain what we mean by that in a second. First of all, though, I'd like to review how muscles and joints work, and they work by what's called a force couple. Quite simply, the example I'm going to cite here is the biceps and triceps in the arm. If I want to flex my forearm, signals get sent from my spinal cord to the biceps to contract. At the same time, signals are sent from the spinal cord to the triceps to relax. So the triceps relaxes, allowing the biceps to contract, which flexes the forearm. If I then want to extend the forearm, signals sent to the triceps to contract. At the same time, signals from the spinal cord inhibit the biceps, making it relax, allowing me to extend the forearm. Now, this can sometimes become a problem if, for example, in the first case with the biceps contracting, the triceps has become shortened through, for example, trauma or adaptive shortening, and it can act as a brake. And this might have what been going on earlier on with the hamstrings are quite tight. They could be acting as brakes, which meant the quads were possibly overworking, which would lead to the trigger points or Archer points on the quadriceps. So what about this Trendelenburg test? As in a normal walking gait, as I kick off with, say, for example, my right foot, and my right foot leaves the ground, the body weight of my upper torso would cause the right hip to collapse or to fall down, as you can see in diagram A. However, the glute medius on the standing leg, which connects the iliac crest or the ilia to the greater trochanter of the femur, contracts, and that keeps the hips level. However, if that glute medius on the standing leg is quite weak, then when you lift that right leg up, the actual hips would drop down. And this would be an indication that there could be a possibility with glute medius on the standing leg. It could be the person is got not very good balance, so you need to confirm it with manual muscle testing, which I'll go to in a second. So on my postural assessment of a patient, what I'll do quite simply, get the patient to lift the leg up, and you can see here I've got my colleague to lift his right leg up, and the left and right hips remain level. However, if you was to lift that right leg up and the right hip, the iliac crest, dropped, then it would indicate a left glute medius weakness or possibility. But it's not written in stone. That then need to be confirmed. We'll get the patient to sit down. I'll put my hands on the outside of both legs and I'd push the legs inwards and get the person to resist me and see if there's any weakness one side or the other. And in our patient here, there was confirmed weakness on the right-sided glute medius. So he had right-sided glute medius weakness, and glute medius is part of the foot Xiaoyang channel sinew meridian. So that was a confirming test that there was a problem with that right Xiaoyang gallbladder. What I have found in the past is that if there is right-sided weakness, when I press, if I wanted to strengthen the chi going up the channel, you tend to press on source points. And what I found quite interesting is that pressing on gallbladder 40, which is the source point for the gallbladder channel, and that often is quite tender, and it was in this case. Then I would repeat the test while pressing on gallbladder 40, keeping my other hand on the iliac crest, and often you find that the hips then remain stable, which is quite an interesting observation, and that would confirm by pressing on the points that are making a difference to either range of motion or, in this case, stabilization. So that confirmed to me that in this particular case, there was right-sided weakness on that foot Shaoyang gallbladder channel sinew meridian. So that's an example of integrating Western orthopaedic examination together with Chinese medicine diagnosis to come up with a possible treatment plan. So from a TCM point of view, both from pulse, tongue and questioning, I would diagnose with my patient here liver qi stagnation, also signs of damp and spleen qi deficiency. The patella maltracking that was causing the patella to rub against the bone. That was possibly was causing the arthritis, the inflammation, and that was quite possibly caught by the tight hamstrings, causing the quads to overwork and possibly maltracking there. But what caused that to occur beforehand? And that, to me, in my thought processes, was this deficient Shaoyang channel sinew. The weak glute medius was not doing its job properly, and then other muscles were being recruited to compensate. And quite often with a weak glute medius, you'll find glute maximus and tensor fascial lata at the front and back will often be recruited, and they to actually cover the glute med weakness. Now they feed into the actual IT band. So if those two muscles are quite tight, it's going to pull on that IT band and it's going to make that quite taut, and that will actually alter the knee biodynamics. So to me, the problem here was this weak glute med. What was that? Why was the glute med quite weak? Well, it could be it's been switched off by its antagonist. And the antagonist to glute medius is the hip adductors, which is the liver channel sinew and spleen channel sinew. And that was proven by, quite simply, I abducted the left leg, and that was actually able to abduct passively to about 50 degrees. And when I abducted the right leg, it was only about 30-35. There was a restriction on when I was passively abducted that right leg. So what I then did is a channel sinew stretch to stretch out that right leg. And then I retested the glute medius, and it was a bit stronger. Not perfect, but it was stronger. So that told me that the liver channel sinew was quite tight. That was switching off the adductors, was switching off the abductors, specifically glute medius, the tensor fascial lata, and the glute medius. If you imagine a letter Y, the stem of the Y being the tensor fascial lata, the IT band, and the two top parts of the Y, one being glute maximus and one being tensor fascial lata. TFL motor point is around about gallbladder 29. If they're quite tight, they're going to be pulling on that stem, and that hooks into the fibula, which is gallbladder 34, and that can actually cause maltracking of the knee. So that was my thought process, all coming from that observation initially, lifting the right leg up, also lifting that left leg up, sorry, and showing right-sided weakness, that Trendelenburg test. So what about treatments? Well, as I said, I've considered the switching off of the glute medius by the hip adductors, the liver channel sinew, and I conducted the channel sinew stretch. Distal points, treating a patient. I want to increase blood flow to the and moisten the muscles and tendons. Liver 3, gallbladder 34 is quite a nice combination. And then local points I will then do with the person side lying, gallbladder 40, to strengthen the yang qi going up the gallbladder channel. That's what source points do. I would also then use Jiang Hua. I find that very, very useful with glute med weakness. Jiang Hua is medial, is halfway roughly. So it's an area halfway between the greater trochanter of the femur and the iliac crest, and it's a general area. And it's roughly where the motor point is for glute med. And I found this both useful both in deficiency and excess cases. Usually I try and needle 3 or 4 inch needle into the area and then put another acupuncture needle, a sun above or below, which is more tender, and then put e-stim across the two, as I'll demonstrate in a second. So this is a 4-inch needle going into a volunteer, showing Jiang Hua, the extra point. So I'm waiting for the release. Feel a bit of resistance there. Another point I find quite useful, especially with a tight IT band, is to actually go to the most tender spot at the distal end of the IT band and put 2 needles underneath the IT band. If you imagine this, the blue circle of the IT band going from you into the screen, ideally you want needles either side. I run about 45-50 degree angles slowly. It's almost like going through butter. If you go the angle too deep or too shallow, you might hit the IT band. It becomes a lot more resistant, but it should be quite relatively straightforward to needle into there, and then again put e-stim across the two, because that tends to, I find, reduce inflammation. As you can see here, this I'm putting one of the 2 needles in. That's the IT band there. That's the most tender spot. And gallbladder 33 there, tender.
Ow.
Yeah. And this side here.
Yeah. Like the back's worse.
Well, we're doing the 2 together in a minute. Going underneath the IT band. So we've discussed the local points I would use for this situation, and the distal points. Now we're doing the e-stim. There's the e-stim of the Jiang Hua, the local point, and again there's the 2 needles either side of the IT band. I hope you found this case study useful, and it sort of demonstrates my approach to dealing with musculoskeletal conditions. If you'd like to know a bit more about my approach of integrating both Chinese and Western orthopaedic medicine, then you can download a copy of an article I wrote from JCM, I think it was Winter 2021, from the JCM website, integrating both Chinese and Western medicine. If you want to attend one of my musculoskeletal courses, I run a 3-day blended learning course. The first day is purely online. You can do it in your own time. You've got 6 months access to the resources, and there I describe the theoretical approaches to applied channel theory and some of the orthopaedic examinations, and that's followed by a 2-day face-to-face session. The class size are quite limited to maximise student feedback. If you go onto my website, eastwesthealth-hub.com, and click on training CPD courses, you'll find information together with course dates and venues on there. You also might find further information on my resources button on the website. I've written a few articles there and blogs with the integration of Chinese and Western medicine. Alternatively, you can email me at eastwesthealth62@gmail.com. If you've looked at this clip on YouTube, please click and subscribe, or click like and subscribe. And also you can follow me on my Instagram account Yoda Braz. If you're interested in the first aid courses that I run, if you look on our Facebook page, Hollis Healthcare and Training Limited, you can find details of the courses there. Hope you found this clip informative, and thank you for your time.